Good day, everyone. I am Dr Mutiat Ibrahim. I'll be speaking about vaccine types and technologies. I am a pharmacist, researcher, lecturer at the Department of Pharmacognosy, Faculty of Pharmacy, University of Lagos. My research focuses on discovery and development of safe, potent, and selective anti-cancer drug molecules from natural sources, including medicinal plants and plant microorganisms. Dr. Ibrahim holds a bachelor degree in pharmacy with master's and PhD degree in pharmacognosy. I have over 6 years experience in teaching with over a decade experience in research methodology. I'm a member of African Organization of Research and Training in Cancer, Nigerian Young Academy, member Pharmaceutical Society of Nigeria, and also a co-editor in the journal Annals of Science and Technology. These are my learning objectives. So pathogens are microorganisms such as bacterium, fungus, virus, or parasites that can get in contact with the body and cause various forms of disease. A pathogen is made up of several subtypes that are usually unique to the specific pathogen and the disease it causes. The subtype of pathogen are usually unique to the specific pathogen and the disease it causes. The subtype of pathogen that causes the production of antibodies in the human body that it gets in contact with is known as antigen. So these antibodies that are produced are important part of immune system. Vaccines contain weakening or inactive parts of an antigen of a pathogen that triggers an immune response in the body. Newer vaccines contain the blueprint of producing antigen rather than the antigen itself, regardless of whether the vaccine is made up of antigen itself or the blueprint, so that the body will produce the antibody. This weakening version will not cause disease in the person receiving the vaccines, but it will prompt their immune system to respond much as it would have on its first reaction to the actual pathogen. Once the immune system has been trained to recognize this, if the body is exposed to that pathogen later, it will attack the pathogen by production of this. All pathogen, there are different types of vaccines. We have the all pathogen vaccines. So for the all pathogen vaccines, the use of there are different types of vaccines. We have the all pathogen vaccines. The use of the all disease-causing pathogen in a vaccine to produce an immune response is the oldest and most well-known method of vaccination. When the pathogen is used in its natural state, it could cause active disease that will potentially be dangerous to the individual receiving it and also risk the spread of the disease. In order to avoid scenarios, modern vaccines use pathogens that have been altered. All pathogen vaccines include the live attenuated vaccine, which contain wild, old, or live form of bacteria or viruses that have been weakened or attenuated, so that they create a protective immune response, but do not cause diseases in healthy people. The weakening is achieved through genetic modification of the pathogen, either as a natural occurring phenomenon or as a modification specifically introduced by scientists. In the lab, the virus is passed through many generations of cells to pick up genetic mutation, which weakens it. Live vaccines tend to create a strong and lasting immune response, and examples include the rotavirus, the MMR, Nasa virus, Chocus, etc. However, live vaccines may not be suitable for people whose immune system does not work efficiently, either due to drug treatment or underlying illnesses. This is because the weakening vaccines pathogen is, in some cases, may multiply so much that it will cause disease in the recipient. Additional doses of booster shots are always not needed for life attenuating vaccines. For the old pathogen vaccine, there's also the inactivated vaccine that contains all bacteria or viruses which have been killed or have been altered so that they cannot replicate. Inactivated virus is obtained in the lab by killing virus with heat or chemical. Because inactivated vaccines do not contain any live bacteria or viruses, they cannot cause disease against which they protect, even in immune-compromised people. They can be mass-produced at a relatively cheaper cost. When given to a patient, inactivated vaccines is strong enough to create an immune response, but they do not always create a strong or long-lasting immune response as live attenuated vaccine. Multiple doses are often required to build up immunity that will offer full protection. Examples of inactivated vaccines include hepatitis A, polio, and influenza vaccine. Another example of a vaccine, another type of vaccine is the subunit vaccines. These vaccines contain one or more specific antigen, or what is called flags, from the surface of the pathogen so that they do not contain any whole bacteria or viruses at all. With this vaccine, immune response with these vaccines, immune response can focus on recognizing a small number of antigen targets rather than the antigen of pathogen. Because they contain pieces of a pathogen and not the whole organism, they cannot make recipients sick or cause infection. It is suitable for people who should not receive live vaccines. So people such as the young children, older and immune compromised people. Subunit vaccines do not always create a strong or long-lasting immune responses like live attenuated vaccines. They usually require repeated doses initially and subsequent booster dose in subsequent years. Adjuvants are often added to subunit vaccines to strengthen and lengthen the immune response to the vaccine. As a result, common local reactions such as sore arm may be more noticeable and frequent with this type of vaccine. Subunit vaccines include protein-based, polysaccharide, and conjugate vaccines. So for the protein-based vaccines, it allows for protective response against a protein on the surface of the virus, bacterium, or secreted toxin. The immune response in this vaccine is against the protein component of the bacteria or virus, not on the sugar coat. Certain proteins on the surface of bacteria or virus help the pathogen cause disease. So inducing an immune response such as proteins can help the body fight against infection or the toxic effect of the toxin. Subunit unit vaccine may either be from the original pathogen or recombinantly. So protein-based subunit vaccine allow for protective response against protein on the surface of the virus. Recombinant protein vaccines are made using bacteria or yeast cells to manufacture the vaccine. A small piece of DNA is taken from the virus or bacterium pathogen and inserted into the manufacturing cells. For instance, in making hepatitis B vaccine, part of the DNA from hepatitis B virus is inserted into DNA of yeast cells. These yeast cells are then able to produce one of the surface proteins from the hepatitis B vaccines, and this is purified and used as the active ingredient in the vaccines. Other examples of subunit vaccines include the human papillovirus vaccine, the meningococcal bacteria vaccines that contains proteins from the surface of meningococcal. Polysaccharide vaccine targets an immune response to pathogenic bacteria that are encased in a layer of sugar. Some bacteria blanket themselves in polysaccharide chain as disguise to hide from the immune system. In the laboratory, protein conjugate is attached to the polysaccharide and injected into the body to teach the body to recognize the polysaccharide disguise as harmful invader. Conjugate vaccine are similar to polysaccharide vaccine as they have polysaccharide components, but the sugar is stuck to a protein so that the immune system will respond to the sugar attached to the protein on the bacteria better than the polysaccharide vaccines. Example of subunit vaccines include the pneumococcal vaccine for the polysaccharide or conjugate vaccine, Haemophilus influenza type B vaccine for the conjugate vaccine, and the sickle cells for the recombinant protein, as well as hepatitis B for recombinant protein. Another type of vaccine is the toxoid vaccines. Some bacteria release toxin, that is poisonous protein, when they attack the body, and it is the toxins rather than the bacteria that the body needs protection against. The immune system recognizing these toxins in the same way that it recognizes other antigen on the surface of the bacteria and is able to mount an immune response on them. Vaccines made from inactivated version of these toxins are referred to as toxoids. These vaccines are not poisonous and they trigger a strong immune response. Toxin vaccines are good at preventing certain toxin-mediated diseases such as tetanus, diphtheria, and pertussis. Booster shots are typically recommended every 10 years or thereabout. Examples of toxoid vaccines include diphtheria, tetanus, and pertussis. Another type of vaccine is the viral vector vaccine that contains virus-like particles or molecules that closely resembles virus but are non-infectious, as they contain no viral genetic bacteria, but they deliver the genetic code of the antigen of a pathogen that the immune system wants to fight. Viral vector vaccine is made up of a small section of a virus genetic material, that is the instruction of the blueprint of a specific protein. The virus shell from another virus carries the gene safely to body cells. They usually trigger a strong immune response. Only one dose of the shot is needed to develop immunity. Booster dose may be needed to maintain immunity. An example includes Ebola vaccine and COVID-19 vaccine. The AstraZeneca and Johnson & Johnson brand of viral vector vaccines carry genetic code of spike protein and build immunity against infection. Another type of vaccine is the messenger RNA vaccine, which can be developed quickly by using the pathogen genetic code. When the vaccine is delivered to the body cells, the RNA material teaches the body on how to make a specific type of protein that is unique to the virus, but does not make the recipient sick. The protein triggers an immune response, which includes the generation of antibodies that recognize the protein. Subsequently, if a person is exposed to that virus in the future, the antibodies are produced to fight against it. High-quality vaccine material can be relatively made quickly by a change in messenger RNA of a formulation to a target new antigen. Examples include the Pfizer-BioNTech COVID-19. Another type of vaccine is the outer membrane vesicle vaccines that are naturally produced by bacteria and are essentially a blend of the bacterial outer cell membrane. It contains many antigens found on the cell membrane, but is a non-infectious particle. It can be modified so that toxic antigens are removed and antigens suitable for stimulating an immune response are kept. Outer membrane vesicle vaccines also naturally act as adjuvants. An example include meningococcal vaccines. There's also the nucleic acid vaccines. Compared to other vaccines, nucleic acid vaccines do not supply the protein antigen to the body. They provide the genetic instruction of the antigen to the body cells, and in turn, the cells produce the antigen which stimulates immune response. They are quick and easy to develop and provide significant promise for development of vaccines in the future. We also have the RNA vaccines that uses messenger RNA inside a lipid or fat membrane. This fatty cover protects the messenger RNA on the first entry and also helps it to gain entry into cells by infusing with the cell membrane. Once the messenger RNA gets in the cell, machinery inside the cell translates it into the antigen protein. Although the messenger RNA lasts a few days, sufficient antigen are made to stimulate an immune response. It is then broken down naturally and removed from the body. RNA vaccines are not capable of combining with human genetic code, that's the DNA. An example of these vaccines include Pfizer and Moderna COVID-19 vaccines. Then the DNA vaccines are typically administered along with a technique called electroporation. This uses low-level electronic waves to allow the body cells to take up the DNA vaccine. DNA must be translated to messenger RNA within the cell nucleus before it can subsequently be translated to protein antigen, which stimulates an immune response. No current licensed DNA presently, but many are in development. Generally, vaccines can be categorized into live attenuated vaccines and the inactivated vaccines. Examples of the live attenuated vaccines and inactivated vaccine are as spelled out on this table, like the smallpox vaccines, the Ebola vector vaccines, the oral cholera vaccines are examples of live attenuated vaccines, while anthrax vaccines, hepatitis A and B, pneumococcal conjugate vaccines are all examples of inactivated vaccines. Looking at vaccine scheduling, timing and spacing of vaccine doses are two of the most important considerations of appropriate use of vaccine. Specific circumstances commonly encountered in immunization practice are the intervals between doses of the same vaccine, simultaneous administration of different vaccines, and the intervals between antibody-containing blood products and live attenuated vaccines. Then looking at the interval doses of the same vaccines. Most vaccines in the immunization schedule require 2 or more doses for development of an adequate and persistent antibody response. Vaccination are recommended beginning with the youngest age group at risk for a disease for whom vaccine efficacy and safety have been demonstrated. Studies have demonstrated that following the recommended ages and intervals between doses of the same antigen provide optimal protection. As a general rule, decreasing the interval between dosing in a multiple dose vaccine series may interfere with antibody response and protection. Then simultaneous vaccine administration. Simultaneous administration of vaccines is defined as administration of more than one vaccine on the same clinic day at different anatomic sites and not combined in the same syringe. Simultaneously, administering all vaccines for which a person is eligible at the same time of a visit increases the probability that a child, adolescent, or adult will be fully vaccinated by the appropriate age. It is also an important part of immunization practice when a healthcare provider is uncertain that a patient will return for additional doses of vaccine. As a general rule, almost all vaccines can be administered at the same visit. However, with exemption include for PCV13 vaccine and the menacral vaccine. They should not be administered simultaneously to persons with functional or anatomic asplenia or human immunodeficiency virus, as HIV patient. So you should not administer PCV13 and menacral vaccines simultaneously. Menacral brand of meningococcal conjugate vaccine is thought to interfere with the antibody response to PCV13, that's the PCV13. When both PCV13 and menacral vaccines are indicated, PCV13 should be administered first, followed by menacral at least 4 weeks later. Another exemption is for an inpatient that is recommended to receive both PCV13 and PPSV23 vaccines. These 2 vaccines should not be administered simultaneously. PCV vaccine should be administered first. However, if PPSV23 vaccine was first administered, PCV13 should be administered not earlier than 8 weeks later in children between 6 and 18 years and 1 year later in adults that are 19 years and older. Immunogenicity studies evaluating responses to PCV13 and PPSV23 administered in series showed a better immune response when PCV13 was administered first. Then we'll look at spacing of multiple doses of the same antigen. Vaccination provider should adhere to recommended vaccination schedule, administration at recommended ages, and in accordance with a recommended interval between doses of multiple antigens provide optimal protection. Administration of doses of a multiple dose vaccine using intervals that are shorter than recommended might be necessary in certain circumstances, such as impending international travel or when a person is behind schedule on vaccination but needs rapid protection. In this situation, An accelerated schedule can be implemented using intervals between doses that are shorter than intervals recommended for routine vaccination. There is a catch-up immunization schedule for children and adolescents who start late or are more than 1 month behind. Vaccine doses should be administered at intervals less than minimum intervals or at age that is younger than minimum. For example, the first dose of hepatitis A has a recommended age of at birth, and the interval between the first and second dose should be minimum of 4 weeks. Before administering a vaccine dose, providers might need to verify that all previous vaccines were administered after the minimum age and in accordance with minimum interval. In clinical practice, vaccines occasionally are administered at intervals less than minimum interval, or at ages younger than minimum age. Doses administered too close together or at too young an age can lead to a suboptimal immune response. However, administering a dose a few days earlier than the minimum interval or age, when you administer between a minimum interval, it is likely to have substantially negative effects on the immune response to that dose. Known as grace period, vaccine doses administered at less than or equals to 4 days before the minimum interval or age are considered valid. However, some local or states might have a different mandate that subside, so that will actually supersede this 4-day guideline. It is worthy of note that the day 1 here is the day before the day that is marked as the minimum age or minimum vaccines for a minimum interval for a vaccine. So the scenarios must be applicable to the grace period. The scenarios applicable to the grace period is a visit to a provider several days prior to the date indicated by the minimum interval, such as when this person has a mild illness. So it is most likely that follow-up is unlikely soon after or even a longer period following this mild illness visit. So the question of whether vaccines can be administered during the mild illness visit or a question of whether a vaccine can be administered during this mild illness visit to avoid missed opportunity to be vaccinated needs to be put into consideration. So doses of any vaccine administered more than 5 days or more earlier than the minimum interval or age should not be counted as valid. So a repeated dose at an appropriate age needs to be given. And the repeat dose for a dose that is not valid, the repeat dose should be spaced after the invalid dose by the recommended interval. Only 14 days. This is influenza doses 1 and 2. If it was administered within 14 days, that's 2 weeks, as a weeks. So the second dose would be invalid and will need to be repeated because the minimum interval between the 2 doses is 2 weeks, not 4 weeks. So a repeat dose will be given, should be administered at 4 weeks or more after the invalid dose. So after the invalid dose here now is the second dose of the Haemophilus influenza vaccine. So repeat dose is counted as the valid second dose. Another instance is if the first dose in a series is given at 5 days or more before the recommended minimum dose. The dose should be repeated on or after the date when the child reaches the least minimum age. So if the vaccine is a live vaccine, ensuring that a minimum interval of 28 days has elapsed for the invalid dose is recommended. First dose of varicella vaccine administered at age 10 as against at age 12 months, at age 10 months as against age 12 months. So you need to repeat those. Repeat dose would be administered no earlier than the child's first birthday, which is the minimum age for the first dose. But if the vaccine is administered at age of 11 months or 2 weeks, repeat dose should be administered not earlier than 4 weeks, which would occur after the first birthday, as after 12. Certain vaccines such as adult tetanus and diphtheria toxoid or pediatric diphtheria and tetanus toxoid increase rates of local or systemic reaction in certain recipients. So careful record keeping, maintenance of patient history, and use of immunization information systems and adherence to recommended schedule can decrease the incidence of such reactions without adversely affecting. In summary, information of the different types of vaccines with emphasis on the level of immunity provided following vaccination has been mentioned. Scheduling of vaccines, including the recommended doses, spacing and time interval of each type of vaccines, as well as specific circumstances commonly encountered in immunization discourse. These are my